All right, so I think I'm really lucky to have picked this topic because, in fact, there's actually very little data. But the reason why I was mean and wanted to start with us introducing ourselves is over the next few hours, it's going to be a very dry few hours if all we do is listen to, well, for sure, me talk. And although we have brilliant speakers, I want to make it as interactive as possible. So you'll see that the presentation itself is purposely very short. Because what I really wanted to do is to talk about your thoughts because there's really actually very little evidence in this regard, and also present some cases to sort of show you guys the range of patients that may want to de-escalate and really give you some practical tips, at least on how myself, Amanda, and Christina approach de-escalation. And for the purpose of this talk, I'm focusing on biologics, but really, you could apply this to basically any drug class for our IBD patients. So when we talk about de-escalation, you can think about it as simple as reduction of dosing. We certainly have a lot of biologics patients who are on, infliximab, and over time they've gone to Q6, Q4, adalimumab, Q weekly, 80 Q weekly, vedolizumab, Q4. And even if you think of non-biologics, you think of your maximum dosing of 4 to 4.8 grams per day. And it really begs the question, can we reduce even the dosing? And then there's total withdrawal therapy. I have to say, there's not a week that goes by that a patient will ask me, is this really forever? Do I have to be on it forever? Can I come off? But again, that can apply to combination therapy. So in fact, there's been some studies looking at withdrawal of the biologic and continuing the immunomodulator, or vice versa, stopping the biologic, continuing the immunomodulator, or stopping the immunomodulator and continuing the biologic. So you get all sorts of different versions. As I alluded to before, we have many questions even about stopping 5-ASA therapy, particularly rectal therapy. And we still have some patients on monotherapy, Imuran or methotrexate. So again, I think this question probably comes up with you guys more than me. And again, that's why I've left plenty of time for us to discuss. So it's very interesting because there's actually been a couple of very good review articles, and I actually was looking at review articles even in the area of rheumatology, because as we know, we share so much with our rheumatologists. And the first thing that pops to mind a lot is this sort of concept of being reluctant, and I say this without any judgment, but really a lot of understanding, that to be on a chronic medication means you're chronically ill. So I think, and again, I would love to have your input. A lot of it isn't even concerns about the drug itself, but more of a holistic feeling that if they're going to be on this forever, it means they're sick forever. And they really are not wanting to accept that for very understandable reasons. There's, of course, the fear of long-term adverse effects. And even though there have been many registries, particularly with our anti-TNF therapy, because they've been around longer, sort of reassuring us that the absolute risk of lymphoma, for example, really isn't higher than the absolute risk from the normal population, there's still fear. And there's still the fear of even, I think, unknown thoughts, right? Or unknown consequences. And I think COVID-19 certainly has really, in fairness, given our patients some reasons to worry about, well, you can never anticipate what's going to happen in the future. So how do you really know that there's not going to be some long-term adverse effect or pandemic or whatever that's going to happen and affect my day-to-day life? We have to understand there is a convenience. We may say, oh, it's every 90 or every 6 weeks, every 8 weeks, and it's 90 minutes, but it's still particularly inconvenient. Even the ones that do sub-Q injection at home, there's still the concept of having to, store it. And when we travel, they have to bring it, or when they travel and they're on infusions, they have to then change their schedule. Side effects, I always call them the common ones. We've all seen them, not joint pains enough to make them incapacitated, but really, they feel it, or some rashes, or some site reactions or discomfort. Even in our Canadian healthcare system, there's still concerns about insurance and copays, and particularly actually those with private insurance, they actually worry very much about sometimes there's a lifetime cap. Another thing I actually picked up from reviewing the literature in both dermatology, rheumatology, and IBD, because we share so many of the same biologics, is this concept of like they've been so well, they almost forget the negative consequences. And I think we all do that even in our own life, about, again, before the pandemic, about even, the last time I had influenza or the last time I had a cold, right? What that really felt like. So there's sort of this regression where it's like, oh, you know what? I'm sure we can just treat me again when I get sick again. It wasn't so bad because in a good way, we've kept them in deep remission for so long. From my perspective and from Amanda and Christina's perspective, we have these conversations all the time is in fairness, because of studies like CALM and REACT, in this era of, I think, very appropriate early intervention, it also begs the question, have we changed the natural history of Crohn's disease and even ulcerative colitis? And if we have changed the natural history, if all this early intervention was to change the natural history, then maybe we should be able to stop treatment. Of course, there's still the concern about adverse events, for example, infections. At the end of the day, as a physician, I do have some responsibility for the bigger system. So there's a concept of cost savings. But every day when I think about these decisions, I'm constantly balancing the risk of drug-related adverse events, patient wishes, societal benefits against really the harmful effects of losing disease control. So there is no right answer. I'm just going to give you two scenarios. We're not going to particularly go into any details about them, but you can see how this comes up very regularly. So a few years ago, I saw a 22-year-old in a healthcare profession. He was diagnosed at age 17 with pan-UC, and actually did very well for a long time on 5-ASA therapy, went into the healthcare profession and as expected started having lots of flares and was very, very compliant. We did oral and rectal, and despite that needed prednisone. Was steroid dependent, so appropriately so. We started vedolizumab and it was relatively slow to respond. So we did a Q10 dose. And then we just sort of went ahead and started him on Q4-week dosing. And I scoped him a couple of years ago and he was like in deep remission, CRP normal, fecal count normal, colonoscopy normal, biopsies normal, no symptoms, normal blood work for about 1 year to a year and a half. And so I said to myself, even, do I really have to continue Q4? This is a lady I actually just saw the other day. She came in to see me with ileal Crohn's disease. She was diagnosed at age 29, had no perianal disease, no history of surgery because of refractory symptoms, was put on adalimumab Humira within her first year diagnosis, did very well the last 8 years, basically has had no further symptoms, normal colonoscopy. But as she was coming in to discuss the biosimilar switch, she asked actually a very good question. She says, well, I've been doing so well, we're thinking about treating anyways. Can I just be on nothing for a while? So you can see how this de-escalation, although poorly studied, can be quite applicable to our daily practice. So, I kind of thought about this then, and that's probably why I, brought up those two cases. The ones that I think are perhaps ones that I would at least consider when they bring it up would be those patients that are in deep remission. And we can maybe afterwards talk a little bit about how we define that. Certainly patients on their first biologic, you feel a little bit more comfortable if you're going to de-escalate, because you feel like you have room to go and there's different agents. And those patients who kind of are tending to have a little bit of adverse events and they're in deep remission. So I guess the patients that seem to always not be able to shake their colds or their joints are really uncomfortable. Rheumatology has ruled out anything significant. It doesn't seem to be inflammatory, but certainly they're sort of just, uncomfortable with some of these symptoms or rashes, and yet their disease is in deep remission. So those are the obvious, scenarios, and I'm happy to talk about it at the end, what other people's thoughts are. I really, really don't stop therapy on anyone who's at risk for short gut. So anyone who's had extensive small bowel surgery, for example, patients who have failed or lost response to more than one biologic. Maybe if you talk to me in 18 months when we have more treatment, I'll go to 2 biologics. But really, I'm worried about patients who've had multiple already other treatments. Perianal disease, I'm very worried about. We're still very limited with our medical management of perianal disease, and I'd be very worried because these patients tend to be on anti-TNF treatment, so I'd be worried about immunogenicity. And I put a question mark against extraintestinal manifestations because certainly we've had to stop patients on biologic treatment for good reasons, and it wasn't even voluntary. And often these EIMs will sort of unmask themselves, so that were very stable for a long time. So that's why I put a question mark. So let's move on to the evidence. This will be the shortest part of the talk because there's very little evidence. There's a lot of retrospective data. There's a lot of meta-analysis of retrospective data, and without a properly randomized controlled placebo trial, having no control group, what these trials all have in common, it's really large, estimations, one meta-analysis said, from 10 to 70% over a year. Well, to be honest, that's not a very helpful piece of information. And I think that just speaks to the lack of controlled trials. If I were to summarize whether or not it's Crohn's or colitis, if you read enough reviews and meta-analysis, for both phenotypes, the relapse rate is as high as 50%, over the first 2 years. So it's kind of like flipping a coin. Up until recently, the best trial was a trial called Story. These were looking specifically at patients with Crohn's disease, and it was an older trial. So these patients were on infliximab, and they're on some type of antimetabolite. So that's azathioprine or methotrexate. And they were in what they defined as at least steroid-free remission for at least 6 months. And this was sort of when the study first started enrolling. This was before we did fecal calprotectin, for example. So this was really based on symptomatic remission. There was, as I said, no control group. And they've published their sort of long-term data. So at a median of 7 years, only a fifth remained in remission, and almost three-quarters of patients had to restart therapy after medium of a year. Of note, if you read the details of this drug, they weren't just stopping, they were only actually stopping infliximab. So a large majority of these patients, at least the first 6 to 12 months, actually maintained their azathioprine and methotrexate. So again, I don't know if this is practical because first of all, eventually people want to come off probably on azathioprine methotrexate anyways. And my own inherent bias is I'm actually more worried sometimes of the anti-metabolite long-term side effects than the biologics. At the median time follow-up of 7 years, there was a mismatch, so it's kind of hard to tell, who's maintained their anti-metabolite. But again, great study. It was the first to try to look at this, but again, very hard, I think, to extrapolate. More bad news, another study, like I said, at 2 years, easily hitting 50% for both diseases where people have a relapse. And this is actually a lovely, lovely study. This is the way we should do these studies. So these are patients that were also with Crohn's disease, had shown clinical, biochemical, and endoscopic remission. Okay, so these patients were scoped. They had fecal calprotectin, and not only did they do that, but they actually didn't know if they were still getting their drug. So this was a study of withdrawal of infliximab. So you could actually get placebo infliximab infusions of presumably just saline, which is really important, right? Because if you think about it, if you think you're coming off drug, you may actually perceive symptoms differently. So this was placebo controlled, and they were randomized, and they were double blinded. So not only did the patient not know, but the person hanging up the drug, your physician, did not know. And so this is the gold standard of how you should do drugs. And their outcome was time to relapse or clinical relapse requiring immediate medical intervention. Having said that, I also in Crohn's disease have no good news. So 50% of patients at 1 year relapsed. So this is the best study, right? There's no placebo effect. There's no nocebo effect. But even in our best done study, half of patients will relapse at year 1. And whether or not you stayed on an immunomodulator made the numbers look better, but there was no difference statistically, which kind of answers the question we had from the previous trial, which is Story. So practical tips for de-escalating biologic, and I get the sense a lot of this is patient driven still. I think patient counseling is key. Just like we do a lot of patient counseling to start treatment, I almost wonder if stopping treatment, we almost need more because there's actually less data and more potential harmful effects. Consistent with guidelines, you need a strategy for disease monitoring. What that is, it sort of depends on what their sign is of their disease. Some people don't mount a CRP, so you need fecal cal. Some people with really mid-small bowel disease, unfortunately, sometimes the only time they tell us they have symptoms is from cross-sectional imaging. So strategies for disease monitoring may not even be that practical. I think it's important to discuss worst case scenarios because if you're withdrawing therapy, you have to bring up worst case scenario. If you can't recapture them, what does that mean for surgery? For example, colectomy. Timing, we can all think of really bad times to stop therapy, right? Patients who are starting new jobs, reaching different milestones in their life. Will they accept steroids for bridging? So if they're sick, the first thing we can do is to start steroids, but are they accepting of it? Do they have significant side effects? So as you can tell, there may be a role, but limited evidence. And so in my practice, I rarely offer it as coming from me, but I have a lot of understanding as to why patients would want this. We certainly will have more data coming from other clinical trials that I highlighted, but even in this clinical trial, they're actually not stopping everything. They're just either continuing combination or continuing either the immunomodulator or biologic. There's also another clinical trial looking at UC patients where they are going to stop infliximab and then treating them sort of as soon as they flare. But again, that's probably going to be a setup for immunogenicity. So I'm sorry I don't have better news from a data perspective. But having said that, this is the best that we have. And although there's no data right now to support it, there's no doubt this is what our patients ask and seek, and we have to be prepared to talk about it. So thank you for your kind attention.